My journey, wanting to go to medical school, thought I would be an orthopedic surgeon, and promptly found out I was about a foot too short and really not into power tools and not really into the pounding and the nails and hammer. Once I got to medical school, I kind of tried everything, but really loved surgery. I knew I was going to be a surgeon kind of from day one, despite almost every single person telling every woman that goes to medical school that you'll never want to be a surgeon. So despite all of the discouragement, I loved surgery. I loved the environment. I loved being able to have a problem in front of us and try to fix it. Went into general surgery residency at USC, so trained at the county hospital. Loved my time there, loved the patients that we got to take care of, and really kind of explored what kind of surgery I wanted to do for a career, and fell into breast. I thought, breast oncology was too difficult. I didn't want to do it. There was just too much to know, and you were going to do 2 operations for the rest of your life, and it didn't seem appealing to me until I met my mentor, who is Dr. Melvin Silverstein, who's one of the giants in breast oncology, who really kind of changed the thought process and focused on really taking care of women, and that cosmesis is an important part of the emotional healing part of breast cancer. So it really inspired me to go into breast oncology and then go on to do what's called oncoplastic surgery in his fellowship. Then left USC. I had spent about 12 years at USC, and then left and started my career up in Seattle at Virginia Mason, and had a great time building a program there. And then about 8 years later, I was enticed to come back to Southern California. I didn't think I would, but you never know what can happen. And so I've been back here for 2.5 years, although it seems like yesterday I just got here. I still keep telling people I just got here. But it's been great being back at the St. John's family. So
that's fantastic. We're super happy to have you here. And Janie and I were both at County Hospital at the same time, which was which is kind of fun to bring that full circle. So there are so many myths around breast. So we're going to try to get through some of them. And if you guys, again, if you have questions, please raise them in the chat, or if you're on Facebook, you can put them in the comment section. I'll follow those. But I think one of the first ones that we'll start with is about mammograms, and hopefully we all get them every year after about age 40. Although Dr. Grumley, maybe you can update us on the specifics of that. But there are a certain percentage of those that come back with an abnormality, and that percentage would also be super helpful to hear. And, when you get the call back, obviously your heart drops and you're like, oh no, is this it? So can you talk a little bit about, when you get a call back, does that always mean that there's something wrong? What are the reasons for that? And what are kind of the percentages?
Yeah, that's a really kind of common thing that I hear about, the dreaded callback. It's like, oh my gosh, I got called back. This is it. This is cancer. I've got to, get my life in order. I got to pull my will together. And the reality is mammograms are not a perfect study. So basically a mammogram is a screenshot of kind of this general look at the breast. Now, I don't know if anybody has actually looked at their own images. And I usually like to, when I see patients, actually pull up the image and show them exactly what we're looking at and why it's so confusing. And I kind of equate it to, like one of those big Where's Waldo pictures. There's so much going on. It's very, very busy, and they're looking for a little pin in a haystack. Obviously sometimes there are some more obvious findings, but in general, there's a lot of findings that you can see that actually are really not anything too concerning, although they just can't really tell with the image that they got. So it's like having like one snapshot of something and being able to fully kind of explore what does it truly look like. We just have to call you back and have another look. So about 20% of women will actually get a call back in their lifetime. So I usually try to tell women when they're first starting screening is that expect to be called back, especially if you're at 45 when you're supposed to start screening. So the recommendations are in general 45 and annually from there. Now there's a lot of different recommendations out there. US Preventative Task Force came out with a study that looked at, maybe we don't need to do it as much. Maybe we could start at 50. Maybe we could do it every other year. The only reason that they made those recommendations is because they were trying to decrease anxiety among women. It wasn't to show that, it didn't help. It wasn't showing us that survival didn't improve with mammograms. It just basically wanted to decrease women's anxiety. I don't think that's a great reason why to reduce the mammogram recommendations, because there still is a survival benefit in doing mammograms annually in women in their 40s, 45 to 50. That was still a survival benefit by doing screening mammograms. But the reason why they kind of backed off from that recommendation is because women in their 40s have very dense breast tissue. It's very hard to decipher. When you have dense breast tissue, it's hard to kind of find the thing you're looking for. When you look at a mammogram, most fatty breasts is kind of a gray, dark color to it. What we're looking for is cancer. Cancer is white. If you have very dense breast tissue, you have a very white background. So it's kind of like trying to find a polar bear in a snowstorm. So there's a lot more callbacks. So there's anxiety associated with the callbacks. But if you actually set it up right up front before you even get your first screening mammogram, that you're going to have most likely dense breast tissue, they might call you back and have a look, but rarely do they have to actually do a biopsy. So, 20% of women get a call back, maybe 10% of those get a biopsy, and then maybe 5% of those are actually cancer. So if you actually look at how many people get called back, it's a lot. Most people don't have anything. We just need to have a better look, whether it's with an ultrasound or with, better images of that specific spot, which is called a diagnostic mammogram. So instead of pressing the entire breast, we just kind of focus on one area. Or sometimes, we need to do other things to really decipher what's going on. But in general, most of the time, the callbacks are not because there's actually cancer there. Most of the time, it's just because they need a better look. So, I really like to make sure that patients understand what the limits of a mammogram is, because then they'll always tell patients, oh, well, my friend had a mammogram every year and they didn't even find her cancer. There are different types of cancers and there are different limits to mammograms. And so understanding that will help ease a lot of that anxiety. Right now, one of the things that I kind of want to make sure everybody understands is, COVID vaccinations are coming out. And so one of the things that most recently we're finding is that they have lymph nodes that show up on mammogram when they have their vaccination, which has now led to additional workup. So one of the questions that our breast center is asking every single patient before they come for their mammogram is, have they gotten a recent vaccination? Because we might find enlarged lymph nodes, and then that might snowball into this big workup. If we know that they've had a vaccination, we'll just ask them to wait 2 weeks, because we'll see those lymph nodes shrink. Then we don't have to go through that workup and get alarmed with it. I've had breast cancer patients, feel a lump, and then you ask them promptly, did you just get a vaccination? And they say yes. And of course it's on the arm, the side that they had the lymph nodes that are enlarged. So just
That's
because
such good information. It's like, so, people don't realize when you get the vaccination and you have those aches and pains and things, it's revving up your immune system to make spike proteins to fight the virus. But that's what your lymph nodes do, right?
Exactly. And so that makes everybody worried that, oh my gosh, there's a breast cancer. We can't find the breast cancer, but you've got these lymph nodes. Then you have to do ultrasounds and you have to biopsy. So just understanding like the physiologic changes that can happen is so important. So if you are going to get a vaccination, try not to get a mammogram right afterwards.
Yeah, that's
really you'll get a call back.
Another question about mammograms. So, if you have an abnormal mammogram 1 year, what are your odds of having another one in the future? And how does that relate to getting your mammogram in the same place? Is that important?
So what we look for in a mammogram, the reason we like it every year is because you have a comparison, right? If you just get on the scale, you don't know if you're losing weight or gaining weight one time. And what we're trying to do with a mammogram is have a comparison. So if you have different time points, we can actually look back to see, hey, that's been there forever. That hasn't changed. It hasn't changed in shape. It hasn't changed in size. It looks exactly the same as last year. Then we know it's stable and it's not something we need to worry about. But if you just go to one center 1 year, they see something, and then you go to a different center and they don't have that comparison, they may end up calling you back for the same thing because they don't know that it's been there forever. So I think it's helpful to have it at the same center because it's easy. They already have your images. They have something to compare it to. And that's exactly what the radiologist does when they get a mammogram is they pull up last year's mammogram, they put it up next to this year's mammogram, and they try to figure out, is there something different? Kind of like those, newspaper, games that you can play, like what's different between the two pictures. Well, the radiologists are very good at that. That's what they're doing all day long, trying to pick out those differences. And that's what helps us pick out very subtle findings that are early cancer signs.
Yeah, and so I think that's really important. I know when we talk about things at the breast conferences every week, and we look at their mammograms from the years before. And even if you move or go to a new place, you can get your old mammogram so that they can compare it, and that's a really helpful thing. I know a lot of people worry about mammograms and the radiation, and I've heard it compared to a cross-country flight, the amount of radiation that you get. So maybe you can talk about that, and then some of the things that people do to avoid radiation, like thermography or sonocine, and what the difference is between sonocine and a full breast ultrasound that you might get in our breast center. Can you talk a little bit about some of those differences?
Yeah, so obviously there's going to be a little bit of radiation associated with a mammogram because you are using an X-ray source. It is about equivalent to a chest X-ray, which is maybe like a percentage of a CT scan. So if you look at all of our scans that we give, it's actually on the very low end of exposure. You're right. I hear that all the time. It's less than, flying across the country. Some people will say it's probably less risk than carrying a cell phone around. The radiation risk is very, very small. We have long-term studies on women who have had mammograms, and we do not see any secondary cancer risk associated with mammograms. So that is not a concern for us. It's uncomfortable to get a mammogram. Most women are like, it must have been a man that created this because it's so uncomfortable. But the thing is, it's not that we haven't been trying to find a better way. There's just really no great way to find subtle changes like calcifications, which can be a very early sign of breast cancer. So calcifications typically are either atypical finding, like atypical cells, which is our abnormal cells, or they can be precancer cells called ductal carcinoma in situ. That's the earliest stage in which we can find breast cancer. You can't see that on an ultrasound. You can't see that often on an MRI. Mammograms are still the best way to detect that very early subtle finding. So that's why it hasn't been replaced by anything else. All those things so ultrasound is really an adjunct to mammogram, right? We use it it really was first developed to look at a specific spot. An ultrasound machine has a probe, you stick it on the spot, you can really see that area very well. It was never designed at the start to be a screening study. A screening study wants a nice big look at a general area. You can get it done quickly and you can pick up subtle changes. Ultrasound is really user dependent. Whoever's holding that probe makes a big difference. So you have to have a very, very good tech who knows how to do it. We didn't do screening ultrasounds when it was handheld because it was almost impossible to be certain that you got every single part of the breast and not miss anything. So it was better for very targeted, this is where I want to look, let's look specifically at this spot. Technology became available where we could actually do something called ABIS, which is an automated breast ultrasound. So instead of using a hand, you put a big box over the breast, and that's like one giant ultrasound that allows us to have a better ultrasound look at the breast. It's very helpful in patients who have dense breast tissue, but again, it doesn't pick up any calcifications. It's never going to help us find that very early sign. Now, thermography is something that people will try to do because they're trying to avoid radiation from the mammogram, but it actually has never been proven to help us find cancer. So it's going off of heat, but not all cancers are hot, and so you can't always find the cancer, and you can find hot things that are not cancer. So it hasn't been proven in a large randomized trial to actually help us find any cancers. And it's unfortunate because we hear lots of anecdotal stories, and I'm sure you've heard some of them, where people have been followed for years with thermography and missed a huge cancer that's been sitting there. So it's not a proven form of detection for breast cancer. Sonocine is a little bit different. So it's using ultrasound, but it's basically taking a cine, which is like a movie kind of shot of this probe going through the breast. It is not a replacement for mammogram because, again, it's not going to pick up any calcifications. It's just looking for masses that might be in the breast. I've seen patients where they've had a big cancer missed by sonocyte. I can't speak on the quality or the technique that's done because we don't offer sonocyte at our institution, but it's another one of these technologies that's out there that's hasn't been proven to really help us detect things. It can find some things for sure, because it is using an ultrasound, just like we use an ultrasound, but it's using a slightly different technology. So really not useful in general. And it's definitely just not a replacement for mammogram, right? So if you're going to do it, I would say it would be in addition to a mammogram, because it's so important to find those fine calcifications and subtle changes that the mammogram can detect where you can't see that necessarily on an ultrasound.
That's super helpful. So it's the calcifications that the mammogram picks up that the ultrasounds can't. So, you know, I hear patients a lot say, oh, I have really dense breasts. They always, my mammogram is normal, but they said I had really dense breasts.
Yeah.
So I know that there are grades of density, and that I think in California it's required that they tell patients that, and that there's a certain level when your insurance will cover an ultrasound. Do you think that's always necessary when you're dense, when your breasts are dense, or, you know, if you have dense breasts, should you get an ultrasound every other year? What advice would you give about that?
So in general, if you have dense breast tissue, you should do a 3D mammogram. That's probably the most helpful thing, right? So a 2D mammogram is basically compressing your breast and shooting one X-ray through it. A 3D mammogram takes slices, kind of like a CT scan. So they're taking a lot of little slices. So you can actually get rid of a lot of that density and help you pick up a lot of stuff. And that's the right study for most people with breast density. I typically like to add on an ultrasound if I know that their family history is very significant for certain types of cancers or breast cancer in general, and that they're young and, you know, there's just a lot going on that makes it very hard for us to read their mammogram. It's not an absolute, but in general, so patients who, you know, have family history or worried about lobular cancers, that tends to show up more on an ultrasound than it does on a mammogram. That's a very small subset of breast cancers. Or they have a significant family history, and we know that their risk is pretty high. So you really want to add it as an adjunct to the mammogram. But the 3D mammogram has actually been shown to be a really effective way to take care of or to screen in women who have dense breast tissue.
So that's a great thing for women to ask about. Okay, so you mentioned cell phones. So I'm going to do a little rapid fire here on some of these crazy myths about breast cancer. And then if you guys have other things, add them in. So do cell phones cause breast cancer?
Probably not. I mean, I haven't seen any studies that shows a causal relationship. I've had patients where I always stick my cell phone in my bra, and that's where I got my breast cancer.
Must have been that.
Yeah, and I'm not sure, you know, the number one risk factor is aging. So I'm not sure the cell phone is enough to cause breast cancer, but
How about bras? Can bras cause breast cancer?
No, bras cannot cause breast cancer.
Oh, keep them lifted, ladies.
Yes.
Okay, how about number 3, underarm deodorant, antiperspirant, can that cause cancer?
They cannot cause cancer. We don't want you to wear it when you come to your mammogram, because sometimes there's metallic specks in it. And so it can actually look like calcifications on a mammogram. That's why we don't want you to wear deodorant when you come for your mammogram.
Excellent. That's great. Okay, so here's the other one. So, and you know this too, sometimes if a patient gets a diagnosis of breast cancer, they give up everything: sugar, coffee, alcohol.
Yep.
Do those cause breast cancer?
So we don't have any study that says it's a causal relationship. I hear this all the time. Sugar feeds cancer, so I cut sugar out completely. But you realize when you tell yourself, I can't have sugar, all you want is sugar, right? It's that kind of depriving yourself so that you can, you know, you're just going to obsess over it. So I tell patients there is no bad foods out there. There are really bad amounts, right? So yeah, you don't want to overindulge in anything. If you have too much, the reason why people believe in this whole sugar myth, I think, is it's more of a confounding kind of factor. So if you eat a lot of sugar, if you have a very high sugar diet, you tend to be a little overweight, you tend to have more body fat. Body fat can give off, you know, adipose tissue can give off estrogen and hormone changes. And I think that might have a little bit of a factor in it. We know that excessive body weight does increase your risk of breast cancer. And so the American Cancer Society has really good recommendations. So what they've basically said is exercise 150 active minutes. That means you have to raise your heart rate, not just go for a little walk, but raise your heart rate 150 minutes a week, which if you add it up, it's actually quite a bit of exercise. And so I think that's important. They say don't lead a sedentary lifestyle. Again, exercising. It says, lower your red meat intake, but more importantly, increase kind of a vegetable-based diet. Not that you had to be a vegetarian and not that you have to be vegan. You just want that balance. And I think, unfortunately, in the States, we kind of overindulge a lot of times with our food intake. And I think that probably plays a bigger factor than specific things. So it's not like you cut out sugar, but then you go and, drink maple syrup, that you're going to be fine, right? So it's kind of that balance of things. So there is nothing that's been proven to be a causal relationship with breast cancer. It's not like you eat sugar, you're going to get breast cancer. And it's not, I've had patients, and I'm sure you've had patients who eat the perfect diet. They're the perfect vegan, they exercise, and they can still get breast cancer. And that's because the number one risk factor for breast cancer, unfortunately, is aging.
Yeah, no, I think
that's cure for that
great.
yet.
Little moderation in all things. And I always tell patients, you haven't wasted any of that. If you have led a really healthy lifestyle and you do get breast cancer, you're going to be better able to then go through surgery or chemotherapy or radiation if you need it. So none of it's wasted. And I love the 150 minutes of elevated heart rate. That's a really good goal for everyone to focus on. I think that's great.
We're all wearing our little watches now, so we can keep track.
Track it. It's a great goal. Okay, so here's another myth. All breast cancers cause a lump that you can feel.
No. So a lot of breast cancers, you can't feel anything. And that's, especially now with great screening, most people will come in and they're like, I felt fine. I got a mammogram. What do you mean I have cancer? I didn't feel anything. It's because we're able to detect things before you can feel it. So everybody says, oh, I'm going to get a lumpectomy. And I'm like, well, we don't really use the term lumpectomy anymore because we really don't feel many lumps. We're not feeling those because we're catching it before you can actually feel it. DCIS, you definitely cannot feel anything. Nothing.
DCIS is?
Ductal carcinoma in situ, or what we consider precancer or stage 0 cancer. You can't feel any of that. That's just microscopic. And,
and that's the calcifications that can be seen on mammogram.
Right. Yeah.
Yeah.
And that's the stuff that we want to catch, because we know that the survival rate for that is 100%. If we can take care of it early, we don't have to pull in chemotherapy. We don't have to do a lot of the treatments that most people fear if we can catch things early.
So if you get mammography, do you still have to do monthly breast exams on yourself?
So actually, we've really deterred people from doing monthly breast exams because I think, one, we usually find things on a mammogram before a patient can feel it. And two, a lot of women will say that I've got such lumpy, bumpy breasts, I have no idea what to make of anything, right? So we actually have not been advocating for monthly breast exams. I do tell patients you should know what your breasts feel like and look like. I think the look is actually more important than the feel. And there are some subtle changes. I don't know if anybody ever looks in the mirror and looks at their breasts, but you actually have to lift your arm up because you can see subtle dimpling and things that are more subtle. So know what your breasts look and feel like is more important than being vigilant about a monthly breast exam. So if you know your breasts are lumpy, bumpy, doing an exam might just make you crazy because you're going to be like, what's that? What's this? Also, if you are going to do breast exams, don't do the little circles that we've all been taught. You're supposed to feel like this, and everything feels like a lump when you do those little circles. Flatten your hand and just run your hand flat on the breast. It's amazing how different the breast feels compared to those little circles that we've been taught for so many years.
Yeah,
it'll be less scary.
Yeah, and it is true. Everyone knows their own breast and where things are, and sometimes it's good to map it out. And if you have a lump in one area, pretend like it's a clock and it's at 3 o'clock, and then you always know that one's there. So every whenever you feel it, you're like, oh my gosh, is that something new? You're like, oh no, that was there.
Yeah. But visually looking at your breast is so important. I've had so many patients where when I'm seeing them and I have them lift their arms up and I'm like, did you see that dimpling right there? Like where it just like pulls right up. And they're like, oh, I've never seen that. And it's like, well, unless you move your arm and actually look at yourself in the mirror, you're not going to notice it. And so those are very subtle findings that I think are important, that women kind of just be aware of. But in general,
like the visual part.
Yeah. Yeah. How like their nipple might look a little different, or, you know, there are very subtle findings that patients can kind of notice before their physician might notice. But mammograms are important because we can typically detect the things way before someone can feel anything or see anything.
Yeah. So one of the things that I hear a lot, and you probably hear too, is, you know, did you get your mammogram? Well, I haven't had one for a couple of years, but I don't have a family history.
Yeah.
So, you know, so I'm kind of clear. So what are the numbers on what percent of patients with breast cancer have a family history? And if you don't have one, do you still have to get mammograms?
Well, like I've said over and over, aging is actually your number one risk factor. So everybody has that risk factor.
Damn.
I know, right? You need to come up with a cure for aging, then we'll be all good. So about 10% of breast cancer is actually related to genetic mutation. So when we think about family history, we think about, is there something inherent in your DNA or in your genetics that puts you at higher risk of developing breast cancer? So of all of breast cancer, only about 10% is actually related to a genetic mutation that's known. So that means we've tested it. We know that this is a mutation that runs in families that increases risk of breast cancer. There's another 10% that's probably family history. So mother had it, sister had it, you know, maternal cousin who's female also had breast cancer, and they've all been tested and they're all negative for BRCA1 and 2. But we still put them in a slightly higher risk category because there's something in that family. It's either a gene that we haven't found, or there's something environmental in that environment that they've grown up in that puts them at higher risk for breast cancer. But the rest of it, so about 80%, is actually either unfortunate events that have happened, some factor that we don't necessarily know about, or just aging, which is unfortunate, but those tend to be less aggressive cancers, which is nice. You know, the genetically linked breast cancers tend to be a little bit more aggressive. They tend to happen in younger patients. So those are all important things for us to know about.
That's excellent. So there's a couple of questions. So back to whether or not you can feel a lump. So there's a difference between ductal cancers and lobular cancers. Can you feel lobular the same as you could feel a ductal?
So the difference between ductal and lobular is in how the cells kind of line up. So breast cells create the ducts that are in the breast, and that's where the milk runs through. Ductal cancers basically are a version of those cells, and they still have the ability to stick to each other. So they tend to kind of clump up together, and it's easier to see and feel because they make this mass. They're all of the cancer cells like to stick to each other because the cells themselves have the sticky molecule. Lobular cancers are different because it's genetically mutated, so it no longer likes to stick to each other. They're kind of just scattering cells. So it's a lot harder to see on a mammogram and a lot harder to see even on an ultrasound. So when patients have a lobular cancer, they'll often say, I had a mammogram last year, it was totally fine. And then I felt a lump. And then you're like, oh, well, that's probably because this is more likely to be a lobular type of cancer because of the way the cancer cells are. When I have a patient, I usually explain it to them kind of like, if you were in a helicopter over a fairground and there's big crowds there and you have these, you know, little kids all in bright green lime shirts. If they all hold hands and clump together, you can see it from a helicopter. But if only 2 or 3 of them break off and hold hands and they're kind of making its way through the big crowd, it's really hard to see exactly where they start and where they end because it's just pushing its way through the normal tissue. And that's what lobulars tend to be. So we tend to find lobulars when patients say, my mammogram was totally fine last year, and then now I feel this lump. And then we can go to surgery and find all of a sudden, oh my gosh, it's even bigger than what we had anticipated. We typically will do an MRI in those patients because MRI is showing us blood flow to the breast. So it can give us a better picture as to where there might be increased blood flow because cancer cells tend to be more active. So that's helpful when we plan out surgery to see if this is going to be larger. But even with an MRI, we can find out on pathology that it's a little bit more than we expect. But it's usually not cells that are all jam-packed together. It's just here's a sprinkling of cells, here's a sprinkling of cells, here's a few more cells, and then the whole span of it becomes quite large.
So harder to see with a lobular. I've heard you give that example before with the campers and the green shorts, and it's such a good visual to understand why it's so much more difficult to see the lobular than the ductal.
Yeah.
So you talked a little bit about MRIs with that and the blood flow and you know, sometimes you'll hear somebody say, oh, you know, I had a lung thing, I got an MRI, so I'm sure my breasts are fine. Yeah. So can you talk a little bit about MRIs and the difference between a breast MRI and if you just get a chest one? And should patients request an MRI because it's not radiation instead of a mammogram?
Yeah, so like I said, MRI is showing us blood flow. A chest MR, where you're just going into the tube and looking at your lungs, you're laying on your back. So your breasts are compressed onto your chest wall, and the coil is really not focused on that. It's focused on your chest wall. So you're not going to get any good detail of your breast by doing a chest MR. If you've ever had a breast MR, you have to lay on your tummy. Your breasts have to fall through these holes so that it's actually expanded out. And then the coil is actually focused on the breast, and you can't really see much of the chest. So, I mean, you can see the heart, but you have no details of the lung or anything else because that's not where the focus is. So if you're looking for the lungs, you don't want to do a breast MR because you're not going to find any, you're not going to be able to tell anything. But if you're getting a chest MR, that's not good for the breast because that's not where the focus is and you can't really see what's going on in the breast. So one does not replace the other. You kind of have to have a dedicated breast MR in order to see any detail. Now, why don't we screen everybody with a breast MR? Well, it's because it's not a great screening tool. So a good screening tool means that we want to pick up as many cancers as possible, but not pick up anything that's not cancer. So it has to be sensitive to pick up things, but it also has to be specific. That means everything that it finds has to be more likely be a cancer than not. MRIs can light up like a Christmas tree depending on the time of the month somebody has their MRI. And you can have blood flow that's actually normal or physiologic, that you're normal, normal findings for your breast based on, whatever the blood flow is. So we don't screen everybody with breast MRI because we will more likely subject them to biopsies and workup and multiple things that don't turn out to be anything. The only times we use screening MRIs are in patients who have a very high risk. So you have a greater than 20% lifetime risk of developing breast cancer. So usually you've had some abnormal, atypical, or precancerous type of biopsy in the past. You have a very high family history of breast cancer or significant family history, or you have a BRCA mutation or some genetic mutation that we know your probability of having breast cancer is really high. So it's really worth kind of the extra workup and the extra, studies and the biopsies, because we really are worried that you will develop a breast cancer. But it's not great for a person who's just of average risk, because we'll probably end up sticking too many needles in that breast and frustrating them more than anything, and not finding any cancers.
Yeah, no, that's great information. And, I think everybody gets really confused when they hear different things and they hear what their girlfriends had. There's a bunch of great questions. So there's another question about breast imaging for women with breast implants. And obviously I have my own take on this, but I'd love to hear what you have to say when a woman has breast implants and what advice you give them about mammogram or what kind of imaging they should get.
Well, ideally they have them behind their muscle. It's a lot harder to image a breast with the implants on top of the muscle because it's harder to push it out of the way. And so you don't get a complete view. So you basically have to be able to pull the breast tissue into the mammogram to be able to fully visualize the breast. So if you have a big implant in the way because it's on top of the muscle, we can't push it away to evaluate the breast. It can be very challenging. In those patients, you might want to think about MRIs or just adding ultrasounds to them because you're going to have a better, easier time, but you're going to miss some of those little tiny calcifications. But if it is behind the muscle, then most technologists are actually going to be able to push that out of the way so that you can get a very good mammogram on those patients. So I still think it's useful. What are your thoughts?
No, I mean, I think that's exactly true. And 20 years ago, it probably wasn't true, right? And you had to get a whole bunch of different imaging, and they would say they couldn't really see anything. But there isn't a radiologist in a metropolitan center in the last 10 years that I've met who doesn't think they can get a really good mammogram. And your point about having it behind the muscle, is excellent. And I talk to patients about that all the time. Like, that gives you the best imaging, because if you think about a little A cup, and when it's put around an implant, it's a big A pancake. And so, being able to pull that away and get the imaging is really good.
Yeah.
You also talked a little bit about genetic testing. And so this is another myth that someone brought up earlier, which is, so, my mom had a BRCA test 10 years ago and she was negative, so I think I'm clear. Or I had one 6 years ago and it was negative, so I'm totally fine, even though I have a huge family history.
Right.
Talk a little bit about genetic testing and the timeline of that, and how you counsel patients or think about that.
So genetic testing, just like anything else, has evolved over time. The more you look, the more people we test, the more we find out. And the way we test has changed completely. How we can figure out, somebody has a mutation versus not, and whether it's a pathologic mutation. We've even seen BRCA non-pathologic variants, right? So just because there's just so much more information now that we have more readily accessible gene testing, the best thing to do is actually be plugged into a good genetic clinic, right? So if you have a high family history, we test them at the time that we see them first, but they all understand that there's updates that happen, right? So if you test negative, especially the patients that test negative, we tell them, if there's new things that come up, we may be calling you back in for testing. I just saw a patient who told me, in 2000, I was negative for BRCA1 and 2. Well, now we test for 8 genes at the start, right, that are breast cancer risk genes, including CHEK2, PALB2, all of these other genes that are associated, not just the BRCA1 and 2. And then if that's negative, we then do 85 other genes to look at whether or not there's a family risk. So there's just so much more information now. And being plugged in, especially with somebody who has a significant family history, being plugged into a good genetic counseling group or clinic really allows us to then keep track of what's being tested currently and update that as needed, which will be helpful, I think, in the future. It doesn't mean that you have to do really anything. Good. Yeah, but it helps us guide, maybe it's colon cancer risk. Maybe it's other things that we need to be looking for, not just breast alone.
Yeah, I think that's great. And so there was another myth, and you kind of touched on this because it's all related to age, and sadly we all keep aging. But if you've had normal mammograms for 10 years or 15 years, like, can you just skip a year? Like, do they have to squish my breast every year?
You can, but the thing is, that's usually the year that we find something, right? I mean, I've had so many patients who have said, I missed last year because of COVID. I couldn't get in, so I skipped it. And now there's a cancer. I can't tell. We can't predict when a cancer might arise. So I feel like, it's a great habit to be in once a year. When we tell patients once a year, it usually ends up being 18 months, 20 months before it's like, I just had my mammogram. Wait, what? It was 18 months ago. So I think being in a regular habit, picking a month, that's your mammogram month, is just important because it can help us detect things early. If you wait another 6 months or another year beyond that, it might be a little bit bigger. It might change our options for treatment. So I think it's worthwhile to be pretty diligent about it. The other question I get asked sometimes is, when do I stop? Like, how old is too old to get a mammogram? Right? Some places will say, once you hit 70, you're good. You don't need to do any more mammograms. Well, now that I've lived in Santa Monica or lived in this area and taking care of patients in Santa Monica, we see 90-year-olds who are still hiking and doing great things. So the reason they say stop at 70 is because they assume your 10-year life expectancy is really low. So you're going to die of something, so you might as well not look. I think of it more as it's a physiologic, if there are competing medical issues that are going to get you in the next 5 to 10 years, congestive heart failure, you've had, you have other major issues like COPD, and you can barely walk up a flight of stairs, you probably don't need a screening mammogram every year because there are other medical issues that are more important. But if you're a perfectly healthy person and there's no reason to believe that you wouldn't live another 5 to 10 years, you should still get your mammogram because it is something that we can treat and take care of and, allow them to go on their way and not have this be an issue.
If you want to live more than 10 years, you should get your mammograms every year.
If you think you're going to live for 10 years longer, and you haven't been on the transplant list for liver transplants and, you don't have all these competing medical issues, I think it's still a good idea. But I do see patients who are still coming in diligently for their mammogram when they have metastatic, carcinoid. And you're like, well, you probably don't need that mammogram, but it is a personal choice. I would probably err on the side of doing it than not, because even if we find it, it doesn't mean we actually have to, treat it like, there's no tomorrow and throw everything, including the kitchen sink at it. Knowing about it helps us kind of manage it.
Yeah. So we have another question, and it's a complicated one because it's about patients who've had a mastectomy, and so there's no breast tissue to look at, so there's no mammogram, and right. It's very dependent on what your individual history is. But what kind of screening do they need? Do they need MRI or ultrasound or exams? Like who do they go to for that information? Because as like different oncologists definitely recommend different paths. Yeah.
Well, MRI, I think, has not been recommended after mastectomy on a screening basis. So if there's something you're trying to work up, definitely. If you feel something, work them up with, ultrasound, MRIs, whatever imaging is appropriate. But for general screening, we don't recommend MRIs, again, because there's been so much change. There's reconstruction, there's so much surgery that's happened that it's hard for them to interpret anything. And the chances of you actually having cancer after mastectomy is about 1% to 2%, right? So it's a really low percentage risk, yet it can be very confusing because there's so much going on. So we don't recommend general screening because, again, you'll probably end up doing more workup for nothing than it's worth. Ultrasounds in general, again, very hard to see anything just because there's very little tissue. I usually just recommend a good clinical exam once a year with either your breast surgeon, or if the medical oncologist will do it, somebody should touch that area and know what it feels like. If there's any bumps, any little pimples that you think look funny, or any little pebbles under the skin, we need to then work it up and make sure that we know what's going on there. What we don't want is for something to, feels like a scar, I'm going to ignore it, I can't have breast cancer. And the scar continues and then it gets bigger and then we find it too late. But I think if they're in touch with their physicians, whether it's their plastic surgeon, their cancer surgeon, their oncologist, they should actually feel that skin and know what it feels like so that they can catch anything that pops up, because it's usually right under the skin. When we do a mastectomy, we take all the tissue down to the chest wall. So there really isn't very much tissue left on the back side. And then once you put an implant in, everything is pushed up to the surface. So, that's what we're looking for, is the surface, and also in the lymph node areas. Those are the areas that we definitely want to focus our attention on.
That's great. Super helpful. I want to just save a little bit of time, and there's still some questions that we'll get back to, and please add questions if you have them. But I want you to tell us a little bit about a couple of the amazing programs that you have at the Margie Petersen Breast Center, like your Breast Health Clinic, and then also the Multi-Disciplinary Clinic, which is for patients with breast cancer who can kind of see all of those specialists that they need to see in one. So can you talk about the Breast Health Clinic and then tell us a little bit about the Multidisciplinary?
Sure. So the Breast Health Clinic came about because, all of us with breast tissue at one point have woken up with like a lump or a pain or something, right? You wake up or you feel something in the shower, you're going, oh my gosh, what is this? I need to get looked at. The usual course is you have to call your PCP. Your PCP has to, get you in the schedule. It takes about a week or two, and then they have to order an imaging. and they have to order the right imaging, and then you have to go schedule that imaging, and then you go get the imaging, and then they're like, oh, well, we need to look a little bit further, so you need this other imaging. And it can be a very long loop, and it usually turns out to be nothing. So for the 3 weeks or the 4 weeks, you're stressed thinking, oh my God, I have cancer, yet it turns out to be nothing. Or even if it is cancer, it takes you that long to actually get a diagnosis. So the breast health clinic was designed to kind of take all of that hassle kind of out of it. Let's expedite that process. So we basically have a nurse practitioner who is trained in breast exams and breast care and the algorithms to kind of work all of the breast issues up. And her appointments can be obtained within 24 hours. So you can call the breast center and say, I feel something, I want to be seen. Her appointments are also linked to imaging because we're right there in the breast center with our breast imagers, so that you can typically get at least a mammogram and an ultrasound the same day that you see her. So within 24 hours, most of those issues will be resolved. We can look at it and say, okay, it feels like it might just be a benign thing. Let's ultrasound it. Oh, it looks like a cyst. Don't worry about it. We don't need to go any further. So instead of going for 3 weeks wondering, oh my gosh, do I have cancer? We can answer that within a 24-hour period. And we want women to feel like, okay, I can come in and ask those questions. She also serves as somebody who can help patients who have just a family history. Like, am I at risk? Do I need to do this? Because breast is changing so quickly. All the recommendations change. It feels like weekly. We're doing mammograms, we're not doing mammograms. We're doing this, we're not doing that. So having somebody who's an expert in it will really help kind of walk patients through what they actually need. So she's available for those types of discussions, and then to follow high-risk patients over time, because they're patients who have a family history. They want to get their mammograms with us every year so that they know exactly what's going on. They can always pick up a phone if there's a symptom or something that's going on. So we really wanted to kind of have it be a very patient-focused experience, right? How can we give you the most value and resolve that issue as quickly as possible? All while kind of keeping their primary care in the loop, which is nice. Tara's worked really well with our primary care doctors here in Santa Monica, letting them know what's going on. And they've built a really nice trust so that they know, even if my patient calls me with a lump, I can just tell them to go see Tara, and we're going to get everything done the way it should be done. So
yeah, I mean, I think that's been so amazing. The patients who've visited there have given just tremendous feedback, and Tara is so knowledgeable and great with them. So that's just a call to the Margie Petersen Breast Center to say, like, I have a concern about my breast, and they'll get connected to Tara or scheduled.
Right. Yeah, they'll get scheduled to see Tara. And if Tara's not available, Dr. Fanter and myself will just step in and see those patients.
Fantastic. So we'll put that information on the Facebook page, just so that everybody's got the phone number and the information, because I think that's great. And then can you give a little synopsis of your multidisciplinary clinic and what that's about?
Yeah, so breast cancer treatment involves a lot of people. There's a lot of cooks in the kitchen. So there's a surgeon, there's a medical oncologist, there's genetics, there's radiation oncologists, there's a radiologist, there's a pathologist. Everybody has to kind of come together and talk to each other. So the typical thing for most women who get diagnosed with breast cancer is they get the diagnosis and then they're like, now what? Where do I go? Where do I start? And some people will start at a surgeon, some people will go to a medical oncologist, and then get shuffled through all the different offices, and it takes a few weeks to kind of do that. What we want to do is also take that and help guide the patients by putting it all in one place. There's a clinic twice a week where our new breast cancer patients will come and they actually see everyone. So they stay in the exam room and the doctors go through. So you see a surgeon, medical oncologist, radiation oncologist, genetics, if it's appropriate. And during this visit, all of us will actually confer with each other and do a little conference with the radiologist. So we're actually looking at images real time. Everybody's seeing the same thing. We come up with a cohesive plan for that patient. So they know when they walk out, are we going to start with surgery? Are we going to start with chemotherapy? What kind of radiation are we going to do? Can we do radiation at the time of your surgery? And that plan is kind of formulated right when the patient is in clinic so that they get a complete picture of how do I make decisions about chemotherapy? How do I know if I'm going to need chemotherapy versus not? Do we have to wait for surgery and get the pathology report before we make those decisions? Or maybe I could just do the radiation at the time of surgery, or maybe that's not the right thing for you. So we really want to provide the patient with a nice, complete plan. And most of our patients will say, it feels like, oh my gosh, the doctors talk to each other. Like they actually know what's going on. It's instead of, oh, what did your surgeon tell you she wants to do? Or what did their medical oncologist? And you become that middle person trying to communicate between doctors, as opposed to your doctors all knowing what's going on. So, we really try to emphasize the team approach, because it really does take a team to take care of patients. And so we want to make sure that that's an easy process. So we do it all in the Margie Petersen Breast Center. And I think patients have really liked, it's a long afternoon or a long morning, but they like the fact that, they're
you
there.
Get everything, all that information at once.
Exactly. Yeah. And then we record everything. So we do an audio recording of the entire visit, so that they actually get a USB drive record so they can take it home. So just in case they haven't picked up everything we've talked about over the 3 hours we've been talking to them, it's a good way to review. Or if they have family members who are unable to come to clinic, they can listen to it as well. So I think they've found it really helpful.
That's great. So we're coming to the end of our hour. There's a couple of other questions. So
Sure.
Here's one. So for patients who have had breast cancer and they have daughters,
yeah.
So the daughters have a mammogram earlier, right? Like it's a huge anxiety moment. Yeah. And it's like, you want your daughters to start having mammograms at age 12. So where does all of that play in, and who do you ask when your daughter should do that?
Well, I think you start with, your breast team. Obviously, they need to assess what that risk is. So there's lots of calculators out there that we can use to kind of calculate what their risk is and when should they start. But the first thing you want to make sure of is that there isn't a genetic link to this. So if there's a genetic link, we definitely want to start mammograms a lot earlier. So if it's BRCA1 or BRCA2, we want to start mammograms even in their 20s and do MRIs. And just to keep track of those patients until they decide they want to proceed with any type of prophylactic surgery. If there is no genetic mutation, we try to reassure patients, especially if this is a 70-year-old woman that comes in, has a screen detected breast cancer, it's low grade, low risk, ER positive, PR, it's really most likely age related. We try to ease that anxiety by saying this is not likely anything that you've passed on to your daughter, and that they should actually have their mammogram starting at 40 or 45 annually, just like everybody else. Now some people will say, well, I got my cancer at 40, but I'm genetically negative. In those patients, we might say it's not a bad idea to start at 40, but we don't typically say, oh, now you have to start at 20. There's no age that we specifically say you need to start at just because your family member had it. The other thing about family history, everybody tells me, oh, I have a family history of breast cancer. It's my second cousin twice removed on my father's side. And you're like, oh, that doesn't actually really play into this. When we think about family history, we think about first degree relatives. So mother, daughter, sister, and then we go to grandmothers and aunts to kind of collect all of that information. It has to be significant for us to actually feel like that's actually a risk factor for that person. But there are calculators, and Tara will actually do this for patients who are worried about their risk. They can actually go through, height, weight, breast density, and, the detailed family history and all of the genetics that's been done in the family. And it'll actually spit out a little risk calculator for them. And then we can decide what's the right type of screening for them based on their personal.
Which is amazing. I think that's the big message is in a lot of what you've said, is that there isn't one right answer for everybody. And so you need to ask questions, and you need to have access to a place like the Margie Petersen Breast Center, where you really can have all of the people who have expertise in all these different areas to make sure that your breasts are healthy.
Yeah, we want to keep them healthy.
We want to keep them healthy. We are so grateful for your time, Dr. Grumley. It's been super educational. We've had a lot of good feedback and comments. I'm sorry that I didn't get to everyone's questions, but it was a great conversation. We went through a lot of myths and got good information out there. So I will put Dr. Grumley's information and the Margie Petersen Breast Center, and especially about the Breast Health Clinic, because I think that's a great thing for people to know about. And I appreciate everyone being here, and we will see you next week.
Great. Hi, Sue. I see Susie's on there. All righty. Take care.
All right. Thank you so much. Have a good evening, everyone.
Everybody.
Bye.
Thank you.